And
So this is the
this is just so interesting to me that this is even an issue.
this is the only slide I put together because get some water.
Yeah.
When you Google or search.
That's your tea.
Oh, okay. Oh, that's it. When you Google or search or look in different textbooks or go to different laboratories at different hospitals, ask them what their normal potassium level is, their normal potassium range. You'll get anywhere from 3.0 to as high as 5.5 as to what your hospital's laboratory considers a normal potassium. This was one particular article that I found, and they define it as 3.5 to 5.0, but mild hyperkalemia is actually as high as 6.0. Moderate is as high as 7.0, and it doesn't even get severe in this one particular category range until you're above 7. But the reason that I wanted to bring this to you, Joe, which we talked about a couple months ago, as why this is a controversial topic, and maybe men, you go to different hospitals and you guys go to different hospitals. As somebody who goes to different hospitals around the country, something that I've noticed in the last 10 years and that didn't exist, I would say back in the 80s and 90s anyway, was there seems to be a very, very high sensitivity that didn't exist long ago about coming off pump with potassium, even as high as above 5.0, where they hold coming off pump, have the perfusionist treat the high potassium in one form or another, whether it's just give bicarb or Z-buff or whatever, and then they'll come off. And I see this a lot, and I've seen it where some surgeons are just absolutely adamant. If you sell them, it's 5.3, well, you have to get it down, or you have to do something before we come off. So backing up to many years ago, we talk about cardioplegia, it was always Plegisol. You did 2 or 3 liters of Plegisol during the case. And back then there was no low potassium, everything was high potassium. So you came off pump almost daily with potassiums well into the 5s and easily into the low 6s. And some days you even had it higher than that, and nobody even discussed it. We just came off pump. And quite honestly, I've seen thousands of cases where it just didn't have any issue coming off pump with an elevated potassium. And we talked about this in one of the previous sessions when this came up. When you're on pump is a different environment than probably anywhere else in the ICU or even in the hospital when the patient starts to elevate their potassium. But just so we can recap from a perfusion standpoint, when you're on pump, all the drips are off, all your inotropes are off, everything is off from anesthesia. You have elevated potassium, usually because of high cardioplegia, so that's going to be something you're going to deal with. And you also have a non-pulsatile flow. So the fact that you have no inotropes going and you have a non-pulsatile flow, the moment that you return the pulsatile flow, and I mean literally within seconds or 1 to 2 minutes, when you return the pulsatile flow, your cellular level sodium-potassium pump regulatories kick in. They don't work very well with a non-pulsatile flow, the sodium-potassium pump on the cellular level. But when pulsatile returns, your body automatically sees a little bit of a high potassium, and the sodium-potassium pumps across the cell immediately be able to begin to bring high potassium into the cell, and it self-corrects literally within 1 to 2 minutes of coming off pump. I've sampled this blood before and seen it drop a half a point to a point within 2 to 3 minutes sometimes, most of the time. Then you also have positive inotropes are going to be turned on. Potassium basically, first of all, is a negative chronotrope. That's what it first of all is. It slows your heart rate down. It slows the QRS complex. Eventually you don't have any flat line altogether, right?
That slows depolarization.
Right, so, but eventually it's going to be a negative inotrope. It's going to be a negative inotrope, but first it's but first it's a huge negative chronotrope, which is easily correctable. So think about what happens on perfusion. I would say 80–90% of us out there, what do we do before we come off? You give a gram of calcium. A lot of times the anesthesiologists give another gram of calcium. Right. They don't tell us, but they give another gram.
But we don't tell them either.
We don't tell them, they don't tell us. So
works out good.
But calcium is a very powerful positive inotrope.
Yeah.
The little bit of a negative chronotrope effect that you have from, let's say, a mild or even in the moderate range on this slide of potassium is quickly counteracted, in my opinion, by a gram or 2 of calcium. Now they're also going to give, there are other inotropes that they're sitting on, right? Your epi and all the things that they have up there. Dopamine.
We try not to have to do that on our cases. I mean, I don't know where you're doing cases, but we don't routinely have epi
Right,
I
but
mean, we might have a little dobutamine or something like that.
whatever
maybe.
Yeah.
We
Right.
try not to, start drips unless we really need it.
You're doing good preservation of your hearts, I'm sure. Because
Yeah, but you go a lot of different places, though. So you go a lot more places than we do.
Yeah,
and
and
that sometimes, we forget. We think all of these, we think heart surgery is heart surgery is heart surgery, and it is, but it isn't. A heart surgeon and a perfusionist and an anesthesiologist is not always the same level and capability everywhere you go. And it only takes one within the system to mess it all up. In some places, it's all three.
It depends on the pieces of the puzzle that are coming together. Sometimes you have traveling surgeons and a traveling perfusionist, and you may even have
Don't even know each other.
I did a case one time, never met any of the people in the room. Never saw a case, never observed a case, didn't know anybody in the room, and fortunately it went well. But you don't know like the expectations of that person. You assume where you were at, it's automatic that certain things were going to happen. You better not think that way when you're in a strange environment. You better think, I'm not sure what's going to happen next,
Yeah.
and vice versa. And so it's easy to have problems.
So funny. The Blue Angels would never do an air show like that. They just all different pilots from everywhere else just show up and all of a sudden take off in these complex aircraft and try doing all of these maneuvers. Even though they all know how to do them, that team is so important to understand what the other person is thinking in order to do this kind of operation, I think, because it's kind of like an air show.
Right.
To do this operation safely for patients. I just find that to be so lacking the respect that what we do deserves, frankly. But that's an opinion. What's your thoughts on this potassium issue, Dr. Samir? We're going to go down the line.
Potassium is like insulting me. I can't stand potassium. I hate. For me, 6-1 to 7, I will start to moderate to treat. I will not come off bypass above 7.
But you would come off at 5.9.
I would come on 5.9. Yeah.
Well,
Yeah,
just to
5.9 is-
recap this, nowadays you can't even get out of 5.5. Forget about getting into 6 and 7s. You hardly ever see that at places that are concerned about potassium. So it's a little different though. It's totally different when you're in the ICU, right? Now your inotropes are running. Your pulsatile flow is happening. And if your potassium is getting away from you, the potassium's getting higher because your renals aren't working or whatever, people aren't going to sit around and wait till the potassium is 6.5 or 7 before they do something about it. They're going to do something about it way into the mid-5s because the trend is going the wrong way. But again, you have the return of the pulsatile flow. Your body's functioning normally, hopefully, sodium-potassium pump is working, and your inotropes are on, and your potassium's still getting away from you. On perfusion, none of those things are the case. So my point from a perfusion standpoint was we're hyperventilating about these high potassiums, and we've not even let the body take care of it or let anesthesia do some things that are going to negate the effects of a little bit of high
Well,
potassium.
you just answered the question. You can cure the minor hyperkalemia with a little hyperventilation. All you have to do is raise the pH. I mean, this is pretty easy to do. I'm not even sure you can give an amp bicarb. You can give a little bit of insulin, a little glucose and insulin. It's such an easy thing to treat. And this reason I brought this up, I'm so glad he brought, this is his topic.
Yeah.
I don't go to these places, thank goodness, because I can't imagine somebody getting exercised, be a little bit, to get that exercised over a potassium of 6. But we are doing cases, and they just did one on Thursday, minimally invasive mitral valve. And how we do it, I think you know our little technique, we give the patient 400 milliequivalents of potassium in a single shot for a minimally invasive mitral valve, right anterior thoracotomy. The potassium is 13, 14, 15, and we leave it there until we CVVH it all off, and we get it down, and we come off bypass on those patients with it at 6.5. We're happy. The heart's beating, and we'll come off for 6 minutes as long as it's going down.
Yeah. That actual patient had some renal issues. I think their creat was actually fairly high. So we actually got it down to 4.7.
Oh, okay. Well, that's good. Yeah, you want to do that.
Yeah.
But the first time I ever did that hyperkalemia technique, believe it or not, was on a patient who was a renal failure patient. And the reason I ended up giving so much is I couldn't stop the heart. that heart was still beating with the potassium of 9. So if you have a patient who is conditioned because of chronic kidney disease, you'll find that those hearts won't stop with whatever potassium you give them. You got to get it to some extraordinary level to stop the heart. It's just amazing. They become conditioned to it.
Now, I did have a conversation with our ICU nurses before I came to this lecture, and they have seen patients with severe dysrhythmias at potassiums of 6.0 and 5.9. They get concerned. They've seen patients that didn't have any effect. Then they have seen some that
Yeah,
do.
but that's in the ICU. You're talking about
Right.
two different phenomena.
Right. I'm talking, that's why I want to make
We're
sure.
on
That's,
pump. We
that's
have
why I
the
want to make
mechanical
clear
support.
that we are talking about two different things.
Of
That's why I
course
want to
we
make
are.
that
Yes,
clear.
and I think that's reasonable. That's fair.
So I guess when you, or let's say you're at a potassium of 5.5, you're on pump, and you're having to Z-buff 2 or 3 liters of saline just to get your potassium from 5.5 down to 5.0.
Which is one of the worst things you can do
Right.
because you're going to dilute now your bicarb. You're going to become acidotic. You're going to flux more potassium intracellular to extracellular because your pH is low.
What are your thoughts about sodium chloride in general as an IV solution?
I mean, I like it to a certain point, but too much of it, you're gonna have that problem.
So Dr., I think his name's Dr. Kelly, is one of the top nephrologists in the country, does a lot of lectures. He started calling, and there's others that are calling for a complete ban on normal saline as an IV solution, period. This global ban on it, because he says your normal sodium intake, your what is it, the FDA normal sodium intake for a person is supposed to be 2,500 milligrams, which is actually a lot. You can get away with far less than that and feel a lot better. I think there's 9 grams of sodium in 1 liter of sodium chloride.
Yeah. Well, I mean, if you give enough sodium chloride, your sodium goes up to 148, 154, 160. You have to use half normal. You got to think about what you're doing.
Right.
You just look at the trend and you just follow the trend. I mean, you're following the trend of your labs.
Yeah, sure.
I mean, you can switch to LR, you can do whatever. Just follow the trend of your labs.
If you see the case starting to go down, then you may Z-buff maybe just 500 of saline.
And if you try, and if like you're having issue with your K, you can start early taking care of it.
Yeah.
And hyperventilating is nothing wrong with it.
Right, absolutely.
I mean,
Transiently. And if you have to give a little glucose, I mean, it's really kind of,
And
look, I mean, to be honest with you, I think
or a
this
little
is,
Atrovent, and there is actually in the market is coming a new potassium binder. There's going to be making life much easier. You know, the IV potassium binder. It's coming to market in the next.
really?
Yes, in
I
the
don't
next
know anything
month.
about that.
I
What
will
is
get
that?
the information for next time for you, boss.
Yeah, that's a
Excellent.
good one. I like
Well, I
that.
like
I never,
that.
I didn't know they had that. A selective potassium binder.
Binder, select potassium binder, IV. No more KXLate, these dramas and all that.
Yes. Yeah, I was thinking about KXLate. We could do that intraoperatively. It'd be tough. but
I'm
you could
sure
do it.
that the OR nurses would love that. Would be the highlight of their day.
The highlight. We love our OR nurses.
Yeah.
You want to throw Jeff online? Hey, Jeff. Sorry about that.
That's all right. Hey, yeah, I wanted to chime in on the Nito topic. I'll first start with this potassium topic since we're on that.
Say that
But
again.
generally, we don't treat. Yeah, I'll talk about the Dalnito after I talk about the potassium. So with regards to potassium, I think, again, that could be just like the blood transfusion, patient-specific. I've seen some patients, particularly your chronic renal failure patients, are able to tolerate a little higher potassium levels than non-chronic renal patients. So usually, you know, we don't treat potassium coming off bypass if it's up to 6, unless we have EKG changes and some other, you know, cardinal signs that it needs treated. Once it gets 6 or higher, though, we will want it treated before we come off bypass. Now, with that said, there's a place I cover per diem across town. So again, I may be institution surgeon specific, but I do think it's also patient specific, and if you're having any EKG changes.
Yeah, I think that makes
With
of course.
respect to the cardioplegia, so we've used microplegia with the Quest for years. I've used it for 20 years, whatever. We never had a problem with it. And then across town, they use Delnito for everybody. Valves, cabbages, antegrade only. I've never used retrograde over there. And I've noticed they do single cross clamp technique, but I have noticed that many times we've had to remain on bypass for an additional 15 to 30 minutes for that heart to recover prior to coming off.
With
A lot
which
of times
technique?
the clamp comes off, and 10 minutes later we try to wean, and the patient's not really looking too good. We got to go back on full support and rest that heart for another 15 to 30 minutes. I've never really seen that with microplegia, unless it's a real sick heart, low EF, or complex procedure.
So, Jeff, let me just ask: you're saying that you see that with Delnito, or you
Yeah.
don't see it with? So you see on Delnito where you're weaning, you're a little slower to wean than when you use the microplege.
Yeah. So my main place of appointment, we always use microplegia, and we really never had any issues. Again, the small site dose, we have doses every 20 minutes, 20 to 30 minutes on valves, and then after each graft on cabbages. That being one doc did distal prox, other guy did all his distals and all his proxies.
Mm-hmm. I mean, I think
And
the
I cover per
concept.
diem at a place across town, and they use all Delnito on everybody.
Mm-hmm. Yeah.
All
and-
antegrade, never gave retrograde. And I have all single cross clamp technique. They'll go up to 90 minutes without redosing.
Mm-hmm.
And I have seen extended periods of reperfusion post cross clamp in order to wean someone off bypass.
Mm-hmm.
I mean, we may be on for 30 minutes after the clamp comes off, after like trying to come off 1 or 2 times, or whatever, with and the heart's just not ready to come off on its own.
Mm-hmm.
I haven't seen that with microplegia.
Well, Jeff, that might not be just washout of the Delnito. That may be stunned myocardium coming back if
Yeah,
it takes you
sure.
that long. Usually,
Well, I think that's caused from washout of the Delnito.
or poor preservation, because he's saying they don't
Yeah,
do
poor
I mean,
any.
it could be a
preservation.
combination of that.
Yeah.
I don't do enough cases over there to really know how often it happens, but in the limited number of cases I have done over there, I have noticed that.
Well, there's definitely
Yeah,
a truth to if you have given the Delnito within even 20 or 30 minutes as a repeat dose, you're going to have 5 minutes or so, sometimes 7 or 8 minutes, where your EKG looks very funky before it normalizes. But once it does, usually the heart, if it's been preserved, is pretty healthy, ready to come off. If you're having to go
And
on
I've
and
never
off,
redosed there. I mean, they've gone 60, 90 minutes on a single dose. So I've never redosed there even at 90 minutes.
Stretching it.
right? So
Wow.
you're probably pushing a stunned myocardium that's taking 30 minutes or so to recover.
Well,
Yeah.
unlike the
Most likely.
pediatric heart, and anyone correct me if you've been kind of quiet. I need to get you into this. Okay, you're not saying a whole lot.
Everybody has good comments. I'm just listening.
Yeah, well, I need you to jump in on this. But what does an atherosclerotic heart diseased heart have different from a non-diseased, especially pediatric heart?
I mean, I don't really have any experience in pediatrics, but I mean, I would imagine, I mean, some of these pediatrics, they probably don't have coronary disease, right? Not like.
Well, they don't have coronary
Right,
disease, but when you
absolutely.
have coronary disease, what do you develop? What do you have more of?
Clogged arteries, right?
Well, yeah, but you have more.
Perfusion.
You have more non-coronary collaterals that develop into the heart.
Right.
Therefore, when you give this single dose of cardioplegia, you may have the cross clamp on, and the native coronary ostia are not being perfused, but the non-coronary collaterals that have been developed are feeding that heart, washing that cardioplegia out.
Right, that makes sense.
That's what I think. I see you shaking your head over there,
that
Dr.
makes
Samir. You're agreeing with me.
Yeah,
That makes sense.
I mean, I said something smart today?
always. You always say something smart. I mean, going for that long period of time with one single shot, I mean,
Is a mistake.
yeah, with the kind of hearts that we all see, and the kind of valves we all see, I mean, I'll be very, very concerned.
I think at 60 minutes, if
And I think that when you have to rest the heart like on bypass for 30 minutes before coming off, That's an indication of that
That is
situation.
indication, yeah.
You've done something wrong.
Yeah.
90 minutes is too long. You have to reduce at least 60 to 70 minutes if you think it's going to be another 20, 30 minutes of ischemic time.
So you think 60 minutes is more reasonable than 90 minutes?
I think 60 minutes.
I mean, 90 minutes is way too long.
That's too long. The standard guideline is for 90 minutes, but I think you're putting the patient at risk, and your preservation is going to be reduced, obviously.
Jeff, you need to send this video to that hospital so they can hear what our comments were. All right.
They can come and attack us.
But I'm just per diem there, so I just go through and do as they do, and don't ask any questions and whatever, you know.
Exactly. I know.
But
Sometimes
I
that's.
do have another question. So this new surgeon we have, because they got rid of our two main surgeons and they brought this new guy in from University of Miami. We use Hyperkalemia on all of his cabbages, and the valve he wants
Myocardial.
modified Del Nido, which is the same ingredients as regular Del Nido, with the exception of the potassium. It's 40 milliequivalents instead of 13. So we give this out of 4-to-1 blood to crystalloid ratio. So my question is, why don't we just use Del Nido for valves, whatever? Because that's what seems to be good for valves. It's like, why don't we just give the one dose? I never asked him this, and maybe I should just ask him myself. And it's like, well, if we're using modified Del Nido, why don't we just use regular Del Nido and give one dose versus just 4-to-1 modified and do a multi-dose cardioplegia with it, you know?
Well, I'll tell you, and I can't answer your question. I don't know if anybody else here can either, but.
Yeah, I was just wondering.
But I mean, I don't know if anybody can answer, please just go ahead. But my view on what you're saying to me is when somebody takes a formula and then they have zero academic laboratory research experience, start modifying it willy-nilly because they think something is probably synonymous to somebody saying in deep Louisiana, watch my beer and hold this.
Yeah.
That's good. That's good.
Yeah, so that's what I think about